Hey, welcome back to my channel. We're here again with Dr. Dean after a brief hiatus. We were both gone for a couple weeks. What's going on, man? You feeling any better?
Well, yeah, considering getting over shingles and getting a nice cold/flu with other travel last week. It's good to be back. There's been popular demand. That's sort of what I said to you earlier when we were planning to do today, that you can't let people down again for another week.
Were you hearing a lot of that at the Arnold? Were people asking you about
I,
that?
I had a few people come up and commented our series has been very educational, informative, and I got a couple of requests. A follower called Harry came up to me and said he was very impressed by what we're covering, and he asked me, could we delve into perhaps DPP inhibitors and
Oh,
delve into like GLP agonists? So
okay.
maybe we'll
We could do
do
that.
we'll
We
do
could do that
an
next week or the week after.
yeah. I'm
I mean,
sure Harry.
on a similar topic, we were going to do something interesting like fat redistribution, right? And fatty
Yeah,
acid metabolism as it varies amongst different types of fat. And I don't really know
yeah.
if there's not a lot of other stuff on the internet about this. I thought it was kind of cool.
Yeah. I mean, it's a concept that probably has been spoken about over the last maybe 10, 12 years in the online space of like a theoretical approach to what happens when you're chronically dieting, of losing fat from one space and then obviously storing it in another. I guess it's sort of the polar opposite to fat spot reduction in that you
Mhm.
can selectively burn fat from a single space. But yeah, it's interesting that fat burning and fat loss, to speak, are completely two separate
I know
things.
people never get that.
And definitely, when we spoke about clenbuterol, about the lipolysis and actually the fatty acid oxidation, that's more like the technical way that we're talking about here. That lipolysis, where you're actually opening that adipose cell to release its fatty acid content. If that isn't directly burned by either mitochondria or by the liver through fatty acid oxidation, you're just going to redistribute those fatty acids back into other adipose cells, or you might actually end up with lipohypertrophy, where you create new fat cells where those fatty acids get stored into.
Yeah. At what point when an adipose cell is at what point is an adipose cell full where it's going to stimulate basically hyperplasia? Is that when it gets completely full? Will it stimulate?
I'm not too sure. I've never really looked at the exact mechanism of when it would initiate the next sort of growth of the next fat cell beside it.
Yeah, I would guess when it gets full, because I know when it gets half full, generally that's when it starts to mess with ghrelin.
Yeah, and then
Body doesn't.
obviously we've seen about the sort of whoosh effect of when you've
Mhm.
depleted the acyl glycerol content of a fat cell. Sorry, the triglyceride content of a fat cell, it'll actually store acyl glycerol in water to try and maintain its volume, which is where that sort of whoosh in body weight changes,
Yeah,
because you have intracellular water retention
making it
first,
like a placeholder.
a placeholder until the fat cells it's sort of a survival mechanism of volume, and then you release that water, and that's sort of where that
Yeah.
whoosh effect comes in.
So where people, in case people don't understand what the whoosh effect is, anyone who's dieted, which I'm assuming is everyone watching this, diet, same as muscle growth, is not linear. It doesn't just go in a straight line. You tend to lose some, and then it plateaus, then it lose some. So every time it's plateauing, that's what you're talking about. Basically, the body's creating a placeholder, and then when it realizes it's no longer needed, then it'll drop out. It's just really just water that's dropping out at that point, right?
Yeah,
And
and normally
anyway,
in like a dietary setup, that's sort of where you'd have strategic refeeds, in terms of like you have this influx of carbohydrate with excessive fluid sort of storage, and then once your body sort of comes to this realization that there's no point in holding this excessive intracellular fluid from the carbohydrate consumption, you lose that intracellular water retention in the adipose cells as well. So you get this whoosh where you sort of go up 2 or 3 pounds, and all of a sudden you drop 4 or 5 pounds.
yeah.
And if you're sort of very tuned into your body, you'll know when a whoosh is coming and when to sort of
Mhm.
strategically refeed to keep up with that demand.
Correct. Yeah. And so, and to back up a second, so fat burning versus fat loss. So initially, triglycerides had to be released from the fat cell into the bloodstream and to be burned. right? But I guess if they're not then burned at that point, then they're restored back in a fat cell. And what we're talking about is, I guess most people just assume they go right back into the same cell that they came out of, but that's not necessarily the case. They kind of go back into wherever they're circulating, and they're next to fat cells. They'll go into those cells.
Pretty much, yeah. And then you have to view how are those fatty acids being taken around the body, and that's with chloromicrons and LDL. So you've got your sort of fat transporters from the liver. So when the fatty acids, when there's not a net capability to use those fatty acids, to get put onto this bus, and the bus just shuttles them off to the next sort of storage site, where I guess lipoprotein lipase will tell it, right, offload these fatty acids into that tissue and move on to the next stop. So yeah, it's not linear of like, okay, we effectively burn fatty acids, say, from the glute area, and then if they're not used, to go back to the glute area. This was sort of like, I guess anecdotally, I've seen it online of people discuss fat redistribution, where someone has gotten relatively leaner in terms of their legs, and the fat's redistributed onto the lower back then. So as the prep's gone on, this one body part has gotten excessively lean, but body weight to speak hasn't really changed. So we know then in terms of mass, the fat is redistributed based on the weight as opposed to the visual appearance.
Yeah. And to touch on the principle you talked about before about fat burning versus fat loss, just so in case people haven't watched any of these other videos. So I think what people misunderstand this is where these super low carbohydrate or high fat diets, they market themselves in this place, right? So you can be in a place where your metabolism is running on fat. That doesn't mean you're going to lose any fat. I know that it's very confusing to people. That the basic principle is the more carbohydrates you eat, the more glycogen you will store, and the less fat you will burn. The more fat you eat, the less glycogen you'll store, the more fat you'll store. What dictates fat loss is the calorie deficit, right? That's physics. So it doesn't necessarily matter, at least in theory, if your calories are coming from dietary fat or if they're coming from carbohydrates, as far as fat loss is concerned. Fat burning just means that you're intaking fatty acid that your body needs to then use as a source of energy.
Yeah. And I mean, only recently I had a discussion with someone of, even when you look at fatty acid oxidation and like thermodynamics, it actually comes down to, like you said, physics. It actually comes down to electrons as opposed to fatty acids being calories. It's all about electrons being generated to feed into the mitochondria, and the mitochondria using these fatty acids to generate electrons, which feeds into the electron transport chain to create ATP. When you think about it, it's quite marvelous and scary to think of what happens on that like microscopic level of what our cells are doing from the foods all the time. And I guess calories in, calories out stands the sort of test of science, but when you get down even further of the thermodynamics and cellular efficiency, that's where some of the arguments of your calorie deficit being a strict calorie deficit falls into, obviously, the organelle health of how efficient are the mitochondria. And, you can test that principle with uncoupling agents, not to go down, completely other rabbit hole of like DNP or ursolic acid, stuff that actually then stops the mitochondria from efficiently using ATP itself or generating ATP itself and having to rely on fatty acids to give it those substrates. So it's definitely, when you look at, I guess, another top level that we spoke about, there's a very interesting paper that I managed to pull up before we chatted surrounding how different fatty acids are stored in the body. And I remember reading this a long time ago. It was published in June 2000, uptake of individual fatty acids into adipose tissue in relation to their presence in the diet. And this paper was sort of pivotal in how I set up my own nutrition years ago, realizing that we store, distribute, and burn different types of fats based on the dietary makeup. And what basically the paper found was, in terms of storage of fatty acids post a meal, they found omega-3 polyunsaturated fats were stored in a minimal amount. Then the next step was saturated fatty acids, then polyunsaturated omega-6s, and then monounsaturated. I found that oleic acid was actually stored in the greatest amount into adipose tissue. So when we sort of look then at how you take that, I guess when you're setting up a dietary fat intake, probably having it based off omega-3s as like your hierarchy, and then your saturated, and then the polys underneath, probably fulfills obviously a metabolic fulfillment of your EPA, DHA, and stuff like that towards cellular membrane integrity, but also giving a source of fatty acids that could be used for energy. But also, I guess the third step is that you don't really store those omega-3s into fatty acids, into adipose cells themselves.
You'd have to have an incredible amount.
And then if you do the reverse of how they're burned, then your polyunsaturated omega-3s are going to be released first, then saturated, and then polyunsaturated omega-6s, and then monos being the last one.
Which is interesting because people always consider, not to go off again in another rabbit hole, but people always consider olive oil to be incredibly healthy. It's not the actual fat that's in the olive oil, which is the oleic acid. It's the oleopurifins that are in the olive oil. It's not the fat, because we actually make, that's why it's not considered an essential fatty acid, is we produce oleic acid. The human body produces plenty of it from, is it stearic acid is the precursor?
As far as I can remember.
I don't remember which one it uses, but it uses one of the saturated fats and then to produce oleic acid. But yeah, it's again something olive oil is unhealthy, but it's not that it's. People I think also get very confused with the term essential and non-essential. Right, essential just means your body does not produce.
Correct.
Right? So technically, when we're looking at omega-3s, we're really looking at alpha linoleic acid. Is that the 3 or is that the 6 one?
I think is that the 6 one?
So linoleic acid would be omega-3. So technically, that is the omega-3 that's essential. But from that, we're going to produce EPA and DHA. Those, which is fish oil, those are technically not considered essential because you technically produce them, except the rate is at 3% because we lack delta 6 dehydrogenase. Whatever the first step, right? There's 8 steps in the breakdown. Most humans are deficient in that enzyme to get to the fish oil. So that's why the production rate is horrible.
Yeah, and that's sort of where people who not sold, but that alpha linoleic acid as a supplement, which is often taken by vegans or vegetarians. Like you said, it's a very, very slow conversion rate where you're maybe, like you said, 3 to 6%, I think, is what you end up converting to EPA and DHA endogenously. But yeah, the whole, I guess, side to it is with lipodystrophy or fat redistribution. We tend to see that then with different disease processes. And also probably has to be a consideration of if you're using lipolytic agents like growth hormone, that you can have this fat redistribution because you're influencing lipolysis in one sense, that if what is released isn't burned, is going to redistribute. So it's something that when you're encouraging high rates of lipolysis, that you need to consider that you might get leaner in one space, but your body part to speak is getting the redistribution of what's not used.
We see that in HIV where they have odd storage patterns of fat, and the growth hormone basically, it eliminates some body fat, but also just helps redistribute it appropriately. So it's not just in the midsection.
Yeah, that visceral fat deposition. And I guess that's where, some of the growth hormone releasing peptides were sort of selectively developed. I think tesamorelin is it that's used for lipodystrophy, more so for abdominal fat. But the other side to that, I guess, visceral fat accumulation comes down to insulin and cortisol's interaction, where you then preferentially store fatty acids, from what I can remember, into visceral adipose when you are in a high cortisol and high insulin environment.
Yeah, and there's other hormones that are going to play a role there as well,
like hepatic lipase and
such. When even I believe estrogen should play a role there as well, right? It's why you typically don't see that in women until they're postmenopausal, and then the fat storage shifts. And again, not that estrogen again needs to be in range. I'm not saying for in men to elevate it to cause that's not going to cause a pleasant fat redistribution pattern. That's just going to make you store fat in your hips and your legs.
Yeah, and you could go down that whole rabbit hole of trying to let your estrogen sit as high as possible without addressing it, because that is probably one of the things that you're going to notice when your estrogen is way sky high out of range, is that fatty acid distribution.
Yeah, we should actually do a video on, there's some new cancer research on the androgen receptor, progesterone receptor, and the estrogen receptor, and how this interplay in cancer. And it kind of helps further what I've been talking about not letting estrogen ride high, right? Because if you stimulate the AR in the presence of high estrogen, you most likely will start to develop some sort of cancer. That's kind of the precursor to those steps.
And I think, isn't that the whole paradigm shift in prostate cancer, that it's an interaction? Before it was vilifying DHT and androgens to speak, and then obviously androgen deprivation therapy still resulted in cases of prostate cancer that it's
or
estrogen.
It worked in a percent because you're then blocking estrogen by default, right? You're reducing the production of it. Yeah, and serum, and with that too, again, we could do it in that one, but the serum DHT as well has been ruled irrelevant as well. That can't enter a cell. So all this time we're looking at serum DHT in blood work, it doesn't really mean anything. It's bound and it's not able to go anywhere.
Yep. I always find it fascinating that with blood work, we sort of, like you've said there, you focus on what's in serum, but what's in serum isn't actually what's inside the cells.
No, except IGF is the same way.
Like estrogen's the clear example of, intracrine production. You make estrogen inside the cell, and then what's in your serum is effectively what has spilled out into the serum from that excess of production. I always laugh that even if your estrogen is normal on your blood work, so you're in that normal range, you still have estrogenic side effects because your intracellular estrogen
can still be
production can still be elevated. That's where, if anyone's interested listening, that Dutch test, the dry urinary test for comprehensive hormones, tracks how much estrogen comes out, is excreted in your urine over a 24-hour period. So you're able to get a better picture on what's inside the cell over a 24-hour period, as opposed to what's in your blood at one snapshot in time.
Interesting.
It's a very useful test that I've used in quite a lot of guys that have, I guess, estrogen dominant symptoms of potentially like low dopamine, skewed serotonin metabolism. And you then see with the urinary excretion that whilst the blood work looks completely fine, the testosterone estrogen ratio is all balanced, when you check that urinary excretion of estrogen, it's actually sky high, meaning that the blood work is quote unquote normal because what's spilling out into the serum is a normal range, when what they're making over the 24-hour period inside the cell is actually sky high.
Interesting. Okay. In the US, the Dutch test is not considered a valid medical procedure, but that would be interesting to dive into as well. I don't know that much about it.
Yeah, I've used it quite a bit. Like, it is one of those functional medicine tests that when you look at its value, you're almost using it like in that sense of, you've got an estrogen value from serum, you're trying to assess what is the total production of estradiol over a 24-hour period, as opposed to a snapshot in time with blood work. And one of the useful things that you can correlate from it is the organic acid testing. And so one of the organic acids that comes out of a homovanillate, which is the byproduct of dopamine, you can use it to sort of look at libido issues in guys who are on TRT, where potentially the estrogen could be too high intracellularly when the serum blood work is saying everything's normal. And verification then is that the dopamine level of the brain, or the homovanillate level in the urine, is extremely low. So you see this imbalance playing out that you'd never catch with blood work. That let's say, for example, I guess UK measurements, the estradiol value was 130 picomole, which I think might be about 35 in terms of like US measurement. You'd look at it and say, okay, well, that's quote unquote normal, and there'd be no instance to have to do anything with aromatase, either aromatase inhibition or lowering total testosterone. But when you do the Dutch test and you see that the estradiol is quite high, the beauty further in the Dutch test is it actually gives you measurable amounts of 2, 4, and 16 hydroxyestrone.
Oh, it does.
So you can actually track where the estradiol is going and if there's issues with the metabolism and excretion of the estrogen. So from like a top level view, it's quite useful when your serum isn't really giving you the full picture.
Okay. So it shows you the hydroxylation as well in the liver.
It
How would you manage that then? If serum estradiol is normal, but the intracellular is high, is there an easy way to explain what the solution would be?
So I guess your first step is to inhibit the aromatase enzyme by, let's say, 20 or 30% and see,
Okay, so you still would manage it that way.
Yeah,
even if the serum is showing normal.
See if the serum was showing normal. So then what you try and do then is you wouldn't be able to rely on the serum as your guide of, obviously, yes, you'd be looking for maybe like let's say you pick a dose of an aromatase inhibitor every 4 or 5 days based on the pharmacokinetics. And we know that that's going to lower aromatization by 30%. You might not actually see that lowering of 30% in serum because you're going to be blocking what's being made intracellularly.
So not as much as going to spill out.
So your serum becomes not really a relatively good guide of how you've inhibited aromatase in that instance. So you'd be relying on Dutch tests of that urinary excretion to show you exactly how you're reducing the total estrogen burden.
Okay.
And that's, to me, that added further complexity of using aromatase inhibitors and using blood work to verify it, because quite often when you're looking for reductions in serum estradiol and blood work, and let's even take the example of, competitive inhibition with primobolan or mastron, like what we spoke about before in podcasts, just because the serum level doesn't quote unquote change too much, intracellular aromatase, I guess estrogen production could be. And it's just one of those ones that when you start to piece it all together, it's not often as simple as saying, well, the blood work is what's dictating what's going on in the whole body. It's the bigger picture of where that hormone's being produced in terms of the estrogen and where it's acting globally.
Yeah, I guess that enzyme is inside the cell. So that's going to make sense you're literally just seeing spillage in blood work.
Yeah. And similarly with like the topic of magnesium, when you do serum magnesium, that was sort of why I said about serum, I guess, red blood cell magnesium content to see how much magnesium is actually inside a specific cell where it resides, as opposed to what's in the serum blood work.
And you were using liver markers to also look at that, right?
And the ALP enzyme. So, it's the liver. You're looking at what's inside the cell as opposed to what's inside the blood.
Yeah. And that's what you told me. Mine was still low, and I increased it, and my sleep improved further when I brought it up even more.
Yeah, and that's when you look at blood, it's one of those things that you're almost playing, I guess, fortune telling of trying to predict what the blood is saying. You're trying to make an extrapolation from the blood work is probably the best way to explain it. That while it does give us great insight, like, lipoprotein metabolism, like what we're talking about here with fats, it's really, again, you're trying to extrapolate, well, what does that lipoprotein value mean in like the next 2 months or the next year, as opposed to, well, that's how much LDL or HDL was in your blood at 8 o'clock on Monday morning.
Yeah, it's more like A1C versus fasting glucose, right?
Exactly.
So like a long-term screenshot versus just that immediate second, which can change, is constantly changing.
Yeah, and that's, from a predictive setting, even pulling it back to like the lipodystrophy, it's not something you can predict or you can understand it's going to happen. It's just a context scenario that if you're in a fat loss phase, this is a very, I guess, real possibility as you continue to lose body fat. Like the whoosh, this can be something that can occur where it's the bodybuilding, to speak, the visual becomes more important than
Then
the
the weight.
actual weight on the scale.
Yeah. One more thing that I thought was interesting about the fat redistribution, you were talking about, we go back to the fatty acid metabolism and the way that the different fats are metabolized. We were touching briefly before we recorded on the appearance of the skin from the different fatty acid compositions. I don't know if you want to touch on that, which is kind of a neat way to look at someone's physique and kind of tell what their diet is consisting of.
Yeah, I guess when you think about it, saturated fats tend to be solid at room temperature. Polys tend to be oil or liquids, and then monos can be a mixture between solid and liquid. Anecdotally, I guess when you feel sort of a caliper check of someone's body fat, like lower back or glutes, you know, the sort of advice was, if something is quite solid in terms of like very hard texture to the skin, to the fat that's been pulled, basically, where you're doing a pinch point check, it tends to be more saturated fat. When you sort of get to a more fluidy texture to the skin, it tends to be more polyunsaturated. You know, basically knowing in terms of the distribution rates versus how they're oxidized, you can sort of see where the whole like stubborn body fat coming from more so solid saturated fat versus more, I guess, liquid polyunsaturated fats being a little bit more easily oxidized and utilized for energy. So I guess it's one of those, like, I guess, old school methodologies of quickly assessing sort of fat source distribution at a body fat site, but still comes back to the thermodynamics of calorie deficit, lipolytic agents, adrenergic receptor distribution, estrogen receptor distribution, which again further makes the whole calories in, calories out argument a little more complex than just you need more of a calorie deficit.
Correct. Cool. Well, I appreciate your time again.
Yeah, it was a pleasure.
We can, for the next video, we can make Harry happy and talk about.
Yeah, it sounds like a
cool. Awesome, Dean. Thank you so much. I'll put your information down below as normal, and hopefully you feel better soon.
Thanks, Kurt. See you next week.